Benvenuti, come sempre ho il piacere di presentare Gianluca che fa gli onori di casa e questo è ENDO-PILS, il nostro webinar internazionale. Benvenuti a tutti.
Ciao Fabio, grazie mille, grazie sempre del tuo supporto tecnico e tecnologico per questi appuntamenti. Non potremmo fare assolutamente senza di te e senza lo sforzo di tutte le nostre commissioni, di tutti voi che lavorate più o meno dietro le quinte per il successo di questa accademia. Quindi grazie ancora. Io come sempre do qualche minuto di cuscinetto prima di dare la parola ad Alexis, presentando un pochino l'attività dell'Accademia. Faccio partire quindi qualche slide. Fabio, dimmi se siamo online con le mie slide. Perfetto. Ovviamente l'inizio è sempre per ringraziare i nostri sponsor, partner, che ci permettono di fare questa attività sempre con più tranquillità da un punto di vista economico e di potervi proporre delle attività sempre più importanti da un punto di vista scientifico. Quindi rimaniamo sempre insieme alle nostre aziende partner con gratitudine. Questo è il quarto appuntamento di questa serie di webinar live internazionali con Alexis Gaudin, presidente della Società Francese di Endodontia, che adesso vi andrò ad introdurre, sulla terapia della polpa vitale. E come al solito sono ancora aperte le nostre serate degli study club sulla terapia della polpa vitale, ne abbiamo fatte già tantissime, abbiamo ancora le ultime serate del 2025 e un po' di serate anche nel 2026 a gennaio prima del congresso. Il nostro ultimo evento dell'anno, Cadaver Lab, è sold out, come al solito ha avuto un enorme successo e anche quest'anno siamo sold out. Tra 10 giorni saremo a Verona per fare questo nostro evento. Se siete interessati a un evento di questo genere potete già mandare una mail per chiedere informazioni per l'edizione dell'anno prossimo. Il congresso ormai lo conoscete tutti, l'appuntamento di fine febbraio a Bologna, ancora una volta un congresso internazionale con un topic d'eccellenza, la minima invasività, con relatori di eccellenza. Quindi avremo un corso pre-congresso con Antonis Caniotis e Ugo Rosa Diaz, il loro famosissimo format sul canal blockage. L'editor del Journal of Endodontics aprirà i lavori congressuali il venerdì, Canal Greaves, e poi avremo tutta una serie di relatori fenomenali e conosciuti in tutto il mondo che si alterneranno sul palco il venerdì e il sabato. Abbiamo anche i nostri premi, i nostri bandi, dei premi di ricerca, dei premi del premio dei casi clinici e delle borse di studio che assegneremo, quindi partecipate numerosi, così come mi raccomando sono partite le iscrizioni al nostro programma di continuing education vivendo, sempre più aggiornato, sempre più intenso. Anche l'anno prossimo faremo un ciclo di webinar, sia italiano connesso col vivendo e sia di nuovo questo ciclo di webinar ENDO-PILS internazionali. E prima dell'ultimo Cadaver Lab della mia presidenza chiuderemo con l'ultimo evento della mia presidenza a Catania, diciamo uno scambio di cortesie col presidente eletto, il professor Pedulla, che ci ospiterà a Catania prima di iniziare la sua presidenza. Tutto questo lo potete trovare sul sito dell'Accademia Italiana di Endodontia scannerizzando il QR code e seguiteci, mi raccomando, per tutte le nostre attività. Sono qui quindi a introdurre il relatore di questa sera, Alexis Gaudin, che è un full-time professor alla Università di Nantes e alla Dental School di Nantes ed è un esperto riconosciuto nella biologia pulpale e nella risposta immunitaria della polpa dentale. Quindi per noi è un grande onore avere qui Alexis, che è presidente della Società Francese di Endodontia. È per me un grande onore perché Alexis è un grande amico e abbiamo con lui, attraverso il suo lavoro, fatto una partnership molto importante tra l'Accademia Italiana di Endodontia e la Società Francese di Endodontia. A questo punto io interrompo la mia condivisione. Alexis, I just have introduced you with few words, but for me, the most important words are about our friendship. Which I am honored to be one of your friends, and so this is my honor, really. You are really, our friendship permits me to have invited you, and thanks to this friendship, I want to thank you because of you are here to share your time with our academy. I also told the people and that as you are the president of the French Society of Endodontics, we have created this beautiful agreement and this beautiful cooperation with between our societies. So I hope you will be able to come to February to our Congress because it will be a very nice way to share sometimes. But we are very good friends with your society, so we share events among each other. And I really thank you so much for this present that you give to our academy to be here to share with us your immense knowledge about the topic of vital pulp therapy. So, Alexis, the stage is yours, and you can share your presentation. And we will see at the end of your presentation with a question and answer moment. So just I will tell in Italian how to do for the question. Sorry, Alexis. Fabio, mi confermi che per fare domande non abbiamo la possibilità di collegarci in diretta alla fine, quindi cosa devono fare i nostri ascoltatori?
Possono semplicemente mettere un commento sul canale YouTube e poi noi lo preleviamo e lo sottoponiamo al relatore alla fine della sua relazione. Per cui mano a mano che hanno delle domande le possono tranquillamente scrivere e poi ci pensiamo noi a portarle in sovraimpressione.
Perfetto. Fabio, qualsiasi cosa dovesse succedere dal punto di vista tecnico, tu puoi intervenire in qualsiasi momento. Alexis, the stage is yours. We will come back at the end of your presentation. Thank you so much.
You can share the screen and you can start.
Okay. Can you see my screen?
Not yet.
Not yet. Just wait.
Okay.
What about...
Yes, now I can see it.
You can see it. Perfect. And can you hear me?
Yes.
Okay. So first I would like to say that I love Italy, but I don't speak Italian at all. But I could get a few words about the friendship as you highlighted, dear Gianluca. It's my great pleasure to open this webinar session, and on behalf of the French Society of Endodontics, I would like to thank the Accademia Italiana di Endodontia for inviting me for this topic about vital pulp treatments, challenges and hopes. And I would like also to take this opportunity to say a few words about events of our two society. I know that you are very active societies and you are a truly source of inspiration for us. So as you said, I would like to highlight one of your events. It's not the only one. I saw that you have diverse courses, but this one for sure we'll try to do our best to come for your national congress about minimal invasiveness, myths or reality. In reality, it's close to the topic of the day. We will see how vital pulp treatments encompass in this concept of minimal invasive dentistry. So your meeting will be in Bologna in next February. And I would like also to highlight our national and international congress that will be held in Marseille in June from 18 to 19th of June. And we have a wonderful panels of speakers, such as Professor Paola Villa from Colombia, Professor Française from Spain, Professor Silvio Taschiri from Italy, and Professor Mitu Kolai from the United States. And the topic will be about endodontic microsurgery. So a few words about myself. As you said, Gianluca, I'm living also in Nantes. It's a middle-sized city in France, located in the west part of France. It's known to be the birthplace of Jules Verne, considered by many as the father of science fiction, and is also the most translated writer in the world. So if you have chance to come, maybe you will see some of his creature around the streets. And I welcome you to come. It will be my pleasure to help you to discover this city. So I'm a professor of endodontics in Nantes, and I'm fortunate to have on the same location the hospital, the university, and also the research lab. The name of this lab is Hermès. It's the largest French lab dedicated to regenerative medicine in France. And in this lab, I'm in charge of a research group about inflammation modulation in bones and teeth. So, coming back to the topic of the day, the vital pulp treatments. These treatments or therapy are not new since they were already depicted by William Pfaff. This book is from the 18th century, and William Pfaff described how to make pulp capping using gold foil. However, we are totally in a new era with new concepts, and the concept at the moment is the minimally invasive dentistry. As we know, the tissue, all the tissue are precious tissue. We know how to repair or replace enamel and dentin. We know how to stimulate the pulp to help to heal, to create some mineralized bridge. We will come on this later on. However, we don't know how to regenerate all of this tissue. That's why we have to do our best to maintain and keep this tissue and keep the pulp alive. So there are different situations for vital pulp treatments. There are, I would say, three different situations or scenarios. The first is when you replace an old restoration, such as an amalgam, to replace by a composite, or the second one is when you are in a context of carious lesion, could be a deep or extremely deep carious lesion. We will also come on this later on. And the third situation is the case for traumatology, where you could have a crown fracture with involvement of the pulp. And we will start with this first video. It's an old video. This case, I think, this lady came 20 years ago with crown fracture and the pulp exposure. So you can see from the palatal view that there is a fracture and the pulp involvement. So after the rubber placement, we decided to go for a partial pulpotomy since we saw the patient around 2 or 3 days after the trauma. So we obtain the hemostasis and then we disinfect the cavity. At that time, we use chlorhexidine. And also for the biomaterials, at that time, we used the white MTA. So we mixed the powder and the liquid, and we used the MAP system or equivalent in order to place the increment of these biomaterials. So the idea is just to gently place the biomaterials and not to pack it on the pulp. So we place the biomaterials, we use paper point to remove all of the excess, and then we apply, so this is the view of the materials, and then we apply a glass ionomer, and then we can put this fragment to stick to bound the fragment again, and you have the before and the after, and the final radiograph where we can see the partial pulpotomy. So there are different situations for the vital pulp treatments, going from the indirect pulp capping up to the specific cases of apexogenesis. Indirect pulp capping is when you are not directly in contact with the dental pulp, but as you know, the dentin is made of dentinal tubules, and in these tubules, the bacteria or the byproduct or even the monomer from the composite we use could reach the dental pulp. So when there is a distance of 0.5 millimeters, 1 millimeter, even 1.5 millimeters, there could have a contact or indirect contact with the dental pulp. The second situation is when you remove an old restoration, and under this restoration, you will have a pulp exposure. That is a bit different from a carious lesion, where you can imagine or guess that there will be an inflammatory response. So in case you would decide to remove one part of the pulp or the total or the full pulp of the coronal chamber, we will use the term pulpotomy. That could be either partial pulpotomy, either a full pulpotomy. And I would like also to emphasize on the apexogenesis, that is the physiological edification of the root, where we really want to promote these treatments to obtain this edification of the roots. So there is a trend, I would say, for 25 years now, for the increasing or the gain in popularity about this treatment. And for example, in the last ESC meeting that was in Paris, or in the last AAE meeting in Boston, I think 1/3 or 30% of the lecture were dedicated to pulp biology. And this trend about these treatments can be explained by different factors, but we have a better knowledge of the pulp biology, and also we see the development of new biomaterials based on the MTA. So this trend can be also explained by the number of publications you have on this bibliometric analysis of the different place where the article comes from, what are the big names in the field, what are the topic also developed around the vital pulp treatments. So most of the publication comes from North America, but some of them also comes from Europe. We also have data from retrospective cohort studies, such as this article from Asghari's team. So it's over 10 years where he assessed the outcome of partial pulpotomy, called miniature pulpotomy in this study, the full pulpotomy, and the direct pulp capping. And the result were over 80% success rate 10 years after the treatment. And as I said, there is the development of new biomaterials that are more or less all derived from the MTA. So these materials were developed by Torabinejad in the 90s. And at that time, the aim was to seal communication between outside and inside of the teeth. So the idea was to find the best biomaterial able to seal the communication. So on the right, you have one of the first articles assessing the sealing abilities of these materials using a leakage study. So what makes these biomaterials really important and crucial for this treatment is they are hydraulic cement. So hydraulic means that they need to have humidity to set. And when there is the hardening of these biomaterials, there will be the production of hydrated calcium silicate and the well-known calcium hydroxide. And this element can interact with body fluids and ions from these fluids, such as phosphate, in order to produce carbonated apatite. And this carbonated apatite is one of the precursor of mineralized tissue. And so what we see on this slide is what we call the famous bioactivity of these biomaterials. So now we not only have one biomaterials, we have more than 120 bioceramics that we should call in reality hydraulic calcium silicate based cement, but we also have sealer, different consistency with putty, high flow, and for us, for the topic of the day, the fast set that are really relevant for the vital pulp treatments. So I have selected just 2 articles about comparison of, around these biomaterials. So this articles was published in Materials 2 years ago, and the design of the study is really complete with all different studies about viability of the cell, cytocompatibility, antibacterial property of the cements. So they decided to compare 3 fast sets hydraulic calcium silicate, where they compare the biodentin, the total fill, and the spherical. And as a control in this study, they use the pro-root MTA and the dical, that is calcium hydroxide. So if we jump to the conclusion of this article, this publication, they demonstrated that the biodentin and the total fill outperform spherical in terms of antibacterial properties, in terms of viability, cytotoxicity of these materials. However, all of these results are in vitro study, and what we want is result in real life. So there is also this systematic review and meta-analysis of the different calcium silicate-based cement used for vital pulp treatment, and it was done on deciduous and permanent dentition. And the conclusion of this article is that the pro-root MTA and the biodentin remain the most used and reliable materials for VPT. So it doesn't mean that the others materials did not perform. It just means that this later, the two one, the pro-root and the biodentin, have more studying the effect in vitro, in vivo, and clinical also in human. However, although they have different improvements about their setting abilities, risk of coloration, handling properties, none of them is able to fully regenerate the dental pulp. All the material, the biomaterials we are talking about, are able to stimulate the pulp to create a mineralized bridge that is considered as a healing of the pulp. However, the holy grail, the goal would be to regenerate the pulp. So at the moment, there are different strategies based either with stem cells, so it's a cell-based strategy, or cell-free strategy, such as using some smart scaffold, extracellular vesicle, and so on. But it's not used for daily practice. So I think that there is a room for innovation about biomaterials and vital pulp treatment. And if we have time, we could see this at the end of the lecture. So now I would like that you ask yourself, where do vital pulp therapies or treatment truly belong in your daily practice? How often do you carry out or perform these treatments? Is it once a day, once a week, once a year, once a month? Last year, during different lectures, I've made polls with different groups, and I compared a group of endo specialists with general practitioners. And as expected, the group of endo specialists carried out less vital pulp treatment. Half of this group said that they use this treatment once a year, whereas for the general practitioner, half of them said that they use it once a month. This is not surprising, since the situation for the vital pulp treatment, such as the deep caries and the pulp exposure during trauma, are mostly provided by general practitioners and are rarely referred to pedodontists or endodontists. At least it is the situation in France, but I know that's also the case for different countries in the world. So during this lecture, I would like to consider or share with you who benefits from these therapies and why keeping the pulp alive matters. What are the indications, the case selection, it means when to carry out and when not to perform these treatments. What are the conditions for success? How to perform these vital pulp treatments? So we will review the protocols and the procedures. We will also see what are the current challenges for this treatment, and we will finish by the future considerations. So the first thing is, what are the advantages of keeping the pulp alive? If we want to assess, not to assess, but to reflect or to think about the properties of the dental pulp, the first question that comes to mind is, can we consider the dental pulp as a classic connective tissue, such as the bone or the teeth? We know that there is some cells, such as the fibroblasts, that have extracellular matrix. This tissue is highly vascularized, highly innervated, such as other tissue in the body. However, there are some specific cells organized in a palisade at the periphery of the tissue, and this soft tissue is embedded in a hard shell made of enamel and dentin, which already make him particular, since we know that vasodilatation won't have the same effect in this hard shell than in another place in the body. We know also that These tissues are more immune cells able to react when they are challenged with bacteria. And one of my projects or purpose during my PhD, so it was 10 years ago now, was to decipher the pulp environment in terms of immune cells and molecules. So what I did is that I just recollect some third molar. I open and crack the teeth to get the dental pulp, and then I use two different tools. One is called a flow cytometer, and the other one is a confocal microscopy. So basically, one is to make some images, and the other one is for quantify elements inside the dental pulp. And what I did is I could do a mapping of the different immune cells of the pulp. I could compare the healthy pulp with inflamed pulp. But what I was really interested in is to know whether there was an environment suitable for immunoregulation. And we found with these tools that we could find in the dental pulp some specific subsets of cells, such as the regulatory T cells here, or the tolerogenic dendritic cells in the dental pulp, even without any stimulation. So the presence of these cells constitutes a specific environment suitable for immunoregulation. So even if this is far from our clinical consideration, this could be a future target for biomaterials, and especially for the vital pulp treatments. And if we think about the ability to heal of the dental pulp, it's because there are first the resolution of inflammation. So inflammation, regeneration are going together. And we know that the dental pulp is able to produce tertiary dentinogenesis that could be either reactionary dentinogenesis on the left side here. When there is a mild stimulus, there will be a low-grade inflammation, and the odontoblasts that will be still in place are able to produce this tertiary dentinogenesis. On the other hand, when the stimulation is stronger, so for example, when in the case where there is a traumatic case with a pulp exposure, there won't be any more of the endontoblasts, but there are some specific mechanism inside the dental pulp able to recruit cells from the vascularization, from the dental pulp site itself, from the Hurl's cells, and all of these recruited cells are able to differentiate and to produce a mineralized matrix, and we call these cells odontoblast-like cells, since they are a little bit like the odontoblast because they are able to mineralize, but in fact they are not truly odontoblasts. But anyway, this healing mechanism is truly, for me, fascinating, and this is what we can see here on this radiograph. After the vital pulp treatments, after the 2 or 3 months, we can see with the arrow this mineralized bridge around the biomaterial. Another property of the dental pulp is the ability to elongate and to have the apexogenesis of the root. So if we take these clinical cases, it's a young boy. I think he was 8 years old at the time of the trauma. So he came with almost a pulp exposure. We can imagine and guess where is the pulp. But as he's very young, the diameter of the dentinal tubules are wide, and we decided to perform a small cavity in order to put the biomaterial, at that time was biodentin, and then we bond the tooth fragment. And only by doing this treatment, very simple treatment, we are able to have the fully elongation of the roots 4 years later. On another level of the decision-making process or if we think about advantages of vital pulp treatment, we have to consider what are the alternatives. So usually the alternative is to decide between the vital pulp treatment or the root canal treatment. And if we think about the root canal treatment, what are the expected outcomes for these treatments? So the prognosis is very good, provided we follow the clinical recommendation of the society, the scientific societies. And we have data on this. We have different studies, such as the Toronto study, systematic review also. But on the other hand, we know that the prevalence of apical periodontitis is high among patients, and also the cross-sectional studies that are not made, not as well controlled as the others, show lower success rates. So there is also a discrepancy between the well-controlled studies and the cross-sectional studies. And moreover, our root canal treatment sometimes can lead to different complications, such as perforation. So here you have an example of a perforation in the aesthetic zone. It's a young lady, a nurse working at the hospital. The dentist wasn't able to find or to locate the canal, and lead to perforation that we can manage with different biomaterials, with magnification, with time. Another case where there is a fracture of instrument, we are able to remove this instrument, but at the end, the root is really brittle and fragile. So we can ask the question whether we did the right choice with these treatments. Speaking of the mechanical properties of teeth, there is this famous study where each patient of the study is his own control. They compared the treated teeth on one side of the patient with their contralateral teeth, and they found in this study that the treated teeth had significantly lower survival than their untreated counterparts, and this was particularly true for molars. However, we have to think that the endodontic treatment at the end ultimately has a minimal impact on the mechanical behavior of the teeth. We know that the desiccation is around 7 to 8%, but we have to think about the reason for which we are doing the root canal treatment. And we know that if we lose, or the patient lose one marginal ridge or two marginal ridges, the fracture resistance of the teeth will decrease about 63%. That makes me think about the new design for access cavity. We have seen, especially on social networks, some specific design from conservative to ultra-conservative through cavity, through composite restoration, keeping the roof. These are truly skilled access cavity. However, in this literature review, nothing demonstrates that it has an impact on the resistance of the tooth. And on top of that, we know that it leads to many difficulties in terms of canal localization, in terms of disinfection, obturation. Another topic about the advantages that was not clearly defined a few years ago was the risk of postoperative pain. Now we have different data with systematic review and meta-analysis telling us that the full pulpotomy, in case of water-pulp treatments, have a lower incidence of postoperative pain when compared with root canal treatment. And there is also a result about the fact that this treatment improved quality of life. If we broaden a little bit the discussion, the reflection, and we think about the concept of the cost effectiveness of this treatment, so not only for the patient, but also for the society, we have mathematical modeling of the different scenarios that could happen after the treatment. So on the right side of the slide, you have here what have been done in this kind of study. They compared a water-pulp treatment with root canal treatment, and then they assessed the probability of failure and success and what could be done after the failure of the different case. And all of this was then assessed mathematically. And at the end, they could conclude what could be the best option treatment for the patient. And with this aim in mind, so the concept of the cost effectiveness, they conclude that maintaining the pulpal vitality is preferable over root canal treatment if possible when it comes to the cost effectiveness. And the last argument I wasn't thinking about before preparing this lecture is the environmental impact of the root canal treatment versus the vital pulp treatment. Indeed, climate change has increased awareness of the need for sustainability in our society, but also in healthcare and dentistry. And there are publications and authors, such as this publication, that assessed the impact of endodontic, in particular root canal treatment, on the environmental sustainability. And they found that on average, one root canal treatment would lead to approximately 5 kilograms of carbon dioxide, which is the same as 30 kilometers with a regular car. And they advocate that minimal invasive dentistry and vital pulp treatments, as they don't use the same amount of files, for instance, would ultimately lead to a minimal impact compared to root canal treatment. So on this slide, you have a summary of different advantages of using the vital pulp treatments, and I didn't mention the alarm systems that help the patient to consult, to go to the dentist, and I didn't mention also the minimal equipment required compared to the root canal treatment for doing these treatments. And now we are going to see what are the indications when and when not to perform vital pulp treatments. So it's kind of difficult to end with some decisional tree as the one I'm going to present you. It's based on consensus on different discussion. So for instance, in France, we are doing with the French Society of Endodontics a consensus based on experts in order to communicate with general practitioners in France. So this decisional tree is based on international literature and also expert consensus. So the first things to have is to do or to carry out the proper diagnosis based on history of the patient, of course, the clinical and radiological examination, and we have to obtain the informed consent of the patient. So first situation, the initial diagnosis is the one of healthy pulp or reversible pulpitis, and there is no pulp exposure. So this case, it's the indication for indirect pulp capping. But if you have a pulp exposure, for first situation, it's when it's a non-carious exposure. So let's imagine that you replace an oral restoration, or it's a traumatology cases. Then you have to assess the pulp visually. And what we mean by healthy pulp is when the pulp is uniformly pink and when there are no signs of degeneration or necrosis of the pulp, such as no bleeding, such as a yellowish liquid, dark blood, or the presence of calcified debris. And also, we have to obtain hemostasis within the 5 minutes. So in these specific cases, we recommend the direct pulp capping. Situation is a bit different when there is a caries exposure, or in the case of traumatology, but with a bigger contamination. Situation is different since we think that the inflammation is more important than in previous situation. That's why we advocate for a partial pulpotomy in order to remove one part of the pulp. But as the previous situation, we also have to assess the pulp visually and to obtain the hemostasis within the 5 minutes. Otherwise, we would need to go for the full pulpotomy, and it will be the same. After the end of the full pulpotomy, we have to obtain the hemostasis. We can wait a bit longer. And if it's not possible, we will go for the root canal treatment. And this situation of the full pulpotomy also can be done after a diagnosis of irreversible pulpitis. And I would like just to emphasize a bit on these specific situations. For a long time, symptomatic irreversible was synonymous of root canal treatment. But now we have data of different study. You have a table on the right side of different study where vital pulp treatment was done after irreversible pulpitis on patients. So there are clinical study showing good success rate, and that's why we can consider this vital pulp CRP as a viable treatment alternative for mature teeth with caries exposure. And I would like just to finish this clinical case indication with a case that I treated last year. So it's a young lady, 25 years old, that was referred by colleague oral surgeon. They wanted to, not they wanted, they did. They extracted the tooth 27 because of its particular anatomy and because of the lesion, a big lesion that was around the tooth 27. You can see on this scan that the sinus was completely full. And as they did the surgery and they had to clean all around the tooth 26, they referred me this patient to do the root canal treatment, and also because the patient was painful. So I started the root canal treatment, and just during this treatment, at the moment of the access cavity, I saw that the dental pulp was live and there was no signs of degenerescence of the pulp. So I decided to clean as usual with sodium hypochlorite and then to assess this tissue. And there was sign of healthy pulp. So I changed my mind and I decided to go only for the vital pulp treatment. We used the Biodontin, the new one, Biodontin XP. And for this specific situation, I decided to go to do everything in one appointment. So after the setting of the Biodontin, we can use a composite over the restoration. So just this case is just to illustrate how sometimes we can change our mind based on intraoperative factors. Now let's consider what could be or what are the clinical considerations for success, where there is debate, where there is a consensus. So first situation that makes a kind of debate and discussion is about the terminology, about the diagnosis of the pulp. For a long time, we have been taught and we learned that there is the difference between the reversible and the irreversible pulpitis. But there was a new classification that appears in 2017, the Wolters classification. And the aim of this newer classification was to have a better discrimination of the different status of the pulp, going from the initial to mild to moderate and to severe pulpitis, in order to promote vital pulp treatments. So even if this classification is now was done 8 years ago, the first classification is still ongoing, and the later is quite difficult to apply sometimes from a clinical perspective. However, this year there is a recent publication to validate, to assess this newer classification, and they found that this classification was extremely accurate, and there was truly reliability between the assessor of this classification. The take-home message of this validation of the classification that was to say that first, you can use it safely, and it will lead to most case with vital pulp treatments. However, they still suggest a small modification with 3 categories instead of 4, and to clarify some of the criteria. The detection of a periapical rarefaction doesn't mean that the pulp is totally necrotic and that you can't do vital pulp treatments. There are examples, such as the one here with radiograph, 2D radiograph, or even 3D radiograph, where you can see a periapical rarefaction here and here, where the authors performed the vital pulp treatments, and after that there was the healing and the pulp was still alive. So the take-home message is that it's not because you only have the periapical rarefaction that you can't do these treatments. Another debate is about the remaining dentin thickness and the choice between what we call the selective approach versus the non-selective approach. The selective approach is when you want to remove all the carious dentin at the periphery of the lesion, but you want to leave some soft and sometimes colored dentin toward the dental pulp in order to avoid the pulp exposure. And this is particularly supported by European Society of Endodontology. And on the other hand, you have a non-selective approach where you also open enamel, you clean the carious dentin, but you want to clean everything and you want to access the dental pulp in order to assess this pulp. And this is more supported by the American Association of Endodontists that claim that if you are not able to see the pulp, you can leave some carious dentin, you can have an inflammatory tissue that won't be the good case for the indication. On the other hand, the European Society of Endodontology recommend to use this selective approach in case of reversible pulpitis and in case of deep lesion. They make a difference between the deep and the extremely deep lesion. The difference is for the deep lesion is when you have when you can see sound dentin between the carious lesion and the dental pulp. Whereas for the extremely deep lesion, the carious lesion is already on the pulp. And this difference and the decision-making process is based on two elements. The first is based on histological studies, such as this one, where the authors divided group of carious lesion in two groups. On one side, you have the deep carious lesion, on the other side, the extremely deep carious lesion, and then they perform different histological section and staining. So on the top, you have some blue staining representing the bacteria, and they found that there were differences between the two groups of carious lesion with bacteria that were almost in the pulp for extremely deep carious lesion, whereas it was not the case for the other group. And the other staining is here to see the immune cells, and they found that there was also a difference between these two groups. So from one side, you have histological proof saying that you have a distinction between these two types of caries, and also we have a literature review on cariostis showing that there is very good success rate for selective caries removal. So how to decide? In fact, there is no such big difference between these two approaches, since the European Society recommend to use selective approach for deep caries lesion, but for extremely deep caries lesion, it's the same. The pulp exposure is unavoidable, so you are in the same situation as the complete caries removal. One of the crucial factors, key factors to obtain success for this treatment is to avoid the contamination of the pulp. That's why when we penetrate the pulp, we use sterile burrs. I will come on this later on during the protocols. But another factor also is the ability to have a good marginal seal around the tooth to improve the outcomes of this treatment. So here it's a clinical case with a patient that combined a trauma case with a carious lesion after a fall during a sport event. So we can see here that there is some kind of difficulty to have the optimal marginal seal. So in this situation, what we can do is a margin elevation. So for this, I like to use this type of matrix bend. So you can use on your regular matrix carrier, or you can also use the preloaded one with a tension instrument here. So the idea is to have just the beginning of the tooth and then to access to the pulp. So in this case, what we did was the margin relocalization using a composite. It was, I think, SDR plus Flow Plus from Dentsply. And after we can perform the pulpal exposure, we use biodentin for this case. We wait for the setting of the biomaterials, and as the patient wanted to have everything done in one appointment, we did the impression, optical impression. This is the before and after the impression, and then we were able to bond the ceramic inlays on the different teeth. So I mentioned that minimal equipment is less than root canal treatment, but there are three important things to have in mind or to consider. The first is we have to be able to assess the pulp, so we need magnification, at least gross magnification of 3. We need also to disinfect the cavity, and we need hydraulic calcium silicate cements. So the magnification allows you to assess the status of the pulp, but also the presence of pus or necrosis, or also the attachment of the pulp to the root wall, and what is the dentin aspects. We also have to take into consideration the timing, the size, and the localization of the pulp exposure, since we know, for instance, that a proximal lesion is worse in terms of outcomes than an occlusal lesion. And one of the most studied and described intraoperative factors is the hemostasis, even if there are debates sometimes about what should be the best product and what should be the time duration for the hemostasis. So we need hemostasis, since when there is the hemostasis, we think that we remove all the inflammatory tissue that won't be able to heal. And on the other hand, also, if there is too much moisture from the bleeding, it will be difficult for the biomaterial to set. So if we combine the different study, we can say, and to be compatible also with the daily practice, that the duration of the hemostasis should not exceed 5 minutes. Sometimes it goes to 10 minutes in some study. I've also read 25, 30, but it's way too much, I think. And the product, the best product for hemostasis at the moment, or described in the different study, is the sodium hypochlorite, with also different in terms of concentration, going from 2.5 to 5%. I personally use a 2.5. And also I would like to emphasize that for traumatic cases, it's a bit different, as you don't have so much infiltration of bacteria and so much inflammation. So for trauma cases, I usually don't use sodium hypochlorite. I just let the natural hemostasis. And we have many studies and data regarding the antimicrobial and pulpal lavage, such as this one that show that the pulp survival rates after 1 year was way better for sodium hypochlorite compared to a saline solution. And interestingly, also in this study, they found that the inflammatory state of the pulp tissue that was assessed by measuring MMP9 to the total protein level and the sodium hypochlorite lavage had a significant impact on the pulp survival, whereas the mild preoperative discomfort did not, meaning that the preoperative diagnosis was not so important in this study. I have often this question: is it possible for specific cases where you encounter on one root a necrotic tissue and on the other root signs of vital tissue to combine both treatment? There is this study that was performed on 60 different teeth, clinical study, where they compared 2 groups. The first group where they did root canal treatment, so it's a non-surgical endodontically treated group, versus one group of teeth with one root with VIPT and the other one for root canal treatment. And they found approximately the same success rate, showing that the combination of these 2 approaches is a viable biologically based minimally invasive treatment, provided that you are able to accurately decide what is the status of the pulp. And the idea is first to start with the vital pulp treatment, protect the pulp, and then go for the root canal treatment. And the last condition of factors for success is the use and the proper use of materials. The gold standard for a long time was the calcium hydroxide because of its alkaline pH, because it's biocompatible. It can stimulate also defense and repair mechanism. All of this is totally true. And as I mentioned at the beginning of the lecture, the hydraulic calcium silicate cement, they produce this calcium hydroxide. But we also have data, such as this study, where they found histologically that in this mineralized bridge, there is a tunnel defect. So it's a defect in the bridge that would lead ultimately to bacterial contamination. And moreover, this calcium hydroxide is non-adhesive and can have dissolution over time, leading to this famous tunnel defect. That's why now the gold standard considered for this treatment are the hydraulic calcium silicate cement. And we know from histological study that the mineralized bridge is thicker and higher quality than calcium hydroxide. But we also know that it's not truly dentin. There is no dentinal tubules. It's more like a scar-like tissue. And it's not considered truly as dentin, but at least we want to promote these healing mechanisms. And something that we don't take into consideration, but maybe also will be part of the new biomaterials, is that these cements will have the abilities to release some growth factors that are sequestrated in the dentin. So for the moment, there is no therapeutic that exploit these properties, but maybe in the future. So to summarize on the determining factor for the success of vital pulp treatment, we have, and we know that different parameters can influence positively the success rate, even if usually the quality of the data are quite low. We also know that there are some discrepancies, for instance, with the age of the patient. For a long time, it was considered that young patients had better prognosis. And we have also other studies as showing the opposite, such as also the practitioner experience. Now, let's move to the different procedures, and I will explain, and I will share with you different situations to consider the step-by-step approach of these treatments. So first situation, we are far from the pulp. Let's say it's more than 0.5 millimeters, and it's a trauma case, and the patient comes with his fragment in the hand. The first thing to do is to consider that you have to decontaminate the fragment and to rehydrate the tooth fragment, so at least 20 minutes in a saline solution. During this time, you can perform the anesthesia, the dental dam isolation. Disinfection also of the tooth and the dental dam is crucial. In this case, even if on this picture I show you one case where I place individual rubber dam, I recommend to use multiple rubber dam in order to avoid the pressure of the clamp on the tooth. And then we can bond the fragment using, in this case, etch and rinse in 3 steps. And for the bonding, I like to use flowable composite or composite heated. Another case where the patient doesn't come with the fragments, so you could do a composite in one appointment using, in this case, a stratification composite with microgeography. And if we go a bit further and we think about indirect pulp capping, but in another context, the context of carious lesion. So the beginning of the process is the same. We have to make the anesthesia, to place the rubber dam, to clean the rubber dam, to use magnification, and disinfection of the crown also is important. And then we have to access the cavity. So we start with high speed and water cooling to access the carious dentin tissue. What I like to use for this step is to use ceramic burr and also a manual excavator. And the idea is to clean at the periphery first. So it's a centripetal approach before going toward the dental pulp. Sometimes I have the question about the use of head coming from fluorescence camera or caries detector. For this specific case, I don't like to use them because if we totally follow the colors indication, usually we over clean and we increase the risk of the pulpal exposure. So once the cavity is clean with sodium hypochlorite, we can place the hydraulic calcium silicate. Most of the time I use biodentin because this biomaterial is good in contact with the dental pulp, but it's also considered as a dentin replacement material. If you are quite further from the dental pulp, let's say 1 millimeter, 1.5 millimeters, you can use, of course, glass ionomer or a resin-based material. So let's see with this small video. So after the rubber dam placement and the cleaning of the exterior of the tooth and the rubber dam, we open the cavity using the burr, and then we do the carious cavity cleaning by the periphery. We use at the end of the cleaning the ceramic burr, decreasing the speed to have better haptic control. This is the disinfection of the tooth before the placement of the biodentin, where we don't care about the sculpture of the material at that time. We just want to be sure that there is a good sealing of the material only. Then we see the patient 3 weeks later, and we can do the final restoration after removal of a portion of the biodentin. If we go further and we consider the direct pulp capping, so it's the case of a complete caries removal. The first steps are the same: local anesthesia, dental dam placement, disinfection, opening of the cavity with high speed and diamond burr. What is important at this step is that when we are close when we are close to the dental pulp, we have to change for a new sterile instrument in order to penetrate the pulp. Then we clean the cavity with sodium hypochlorite. I usually use the same as for hemostasis, 2.5%. The hemostasis has to be achieved within the 5 minutes, otherwise we will have to move towards pulpotomy. And also an important thing is that we don't want to put too much pressure with the cotton pellets. So it's gentle pressure with the sterile cotton pellets. And after observation of the pulp, we can gently place the hydraulic calcium silicate. And you can do a direct restoration on 1 appointment or 2 appointments. It depends on your philosophy. So on this case, for instance, I use total fill, and I cover the total fill with a glass ionomer and a composite at the end. If we go deeper, we could perform a pulpotomy. So in this specific case, there was a direct pulp capping on tooth 11 and a partial pulpotomy on tooth 21. So the decision-making difference was made on the deepness of the cavity. It was deeper on the tooth 21. So at the moment, where you access the pulp chamber with the sterile high-speed burr, you have to pay attention to stay in direction of the dental pulp in order to stay as much as possible in the dental pulp, and sometimes could be difficult with a young patient or with central incisor. We use the same product for the hemostasis, no pressure, just gently application of the sterile cotton pellets. And then we apply the biomaterial. So in this case, we applied biodentin on top of the pulp, and we made a small cavity here also to place the biodentin. This is another case of partial pulpotomy. So we saw the patient 2 or 3 days after the trauma. So we decided to go for partial pulpotomy. Otherwise, we could have done a direct pulp capping. And what I wanted to show with this case is, as we wanted to make the final restoration in one appointment because the patient was traveling towards Africa, I think, what we did is that we protect the dental pulp and before the etching, and after the etching, we put the biodentin, and then we did the restoration with the composite. Now we'll see the case of the full pulpotomy. So it's a child, 11 years old, with apex quite immature and with symptoms of irreversible pulpitis. He spent the whole night before without any sleep. It was really painful, but it was just less than 1 day. So after the placement of the rubber dam, disinfection of the tooth, we open the enamel to access the carious dentin. Then we clean the cavity with sodium hypochlorite. We do periphery cleaning, and then we change the burr to open the roof of the access cavity. Then we remove the pulp tissue in the pulp chamber. We clean with sodium hypochlorite. We place the biodentin on top of the tooth, and we wait for 15 minutes, and then we let the patient go, and we see the patient 3 weeks after for the final restoration. Just a few summary about the use of this biodentin. There is no need for cavity preparation. We can apply the biodentin directly to the pulp and to the dentin. We don't need to, we need to avoid maximal pressure, so we don't need to have excess pressure. The manufacturer said that we can wait up to 6 months. I don't recommend to wait so long, especially for cases where you have 1 marginal ridge or 2 marginal ridges. I would recommend just to wait 2 or 3 weeks only. Otherwise, the biomaterials can fracture. And you also have to take in account that if you want to place the material, you need to remove at least 2 millimeters of biodentin. For the follow-up, we see the patient approximately 3-4 weeks after the initial treatment. We saw the patient at 3, 6, and 12 months. We do different sensitivity tests and radiological control in order to see the apparition of a lesion on the radiograph, since sometimes you won't have the answer from the dental pulp because of the size or because of the amount of materials. You maybe won't have the sensitivity test. So on this clinical case, for instance, there was it's a carious lesion with a pulp exposure. We use white MTA at that time and glass ionomer for the first appointment. We saw the patient 3 weeks later. We did the composite as there was no signs and symptoms. And this is the 10 years follow-up of this clinical case. What about the outcomes of this treatment? I think we have to make the distinction between trauma cases and carious lesion. And if we have a look about the numbers, we can be, I would say, disappointed by the numbers. But in my opinion, we don't have to follow the numbers because there is no study that really assess in a prospective randomized controlled trial the difference between full pulpotomy and direct pulp capping. Even if the success rate for pulpotomy in the trauma case is lower than the partial pulpotomy or direct pulp capping, doesn't mean that you shouldn't use them. It just means that pulpotomy for trauma cases are usually performed and carried out with worst cases, with the worst scenario. So it's not an element to, in my opinion, to take a decision. And for carious lesion, it's almost the opposite, where you have a better success rate with complete pulpotomy or full pulpotomies compared with direct pulp capping. It can make sense since for caries lesion, there is more inflammation, so it's more relevant to remove one part of the dental pulp. So with all the advantages we saw, we could ask the question why they are not why they are not so popular in daily practice. There are some barriers that has been identified, and I would like to share this with you. If we're in a situation where there is extremely deep lesion, we usually don't know whether we should go for root canal treatment since it's very good outcomes, non-procedures, and it's considered as the conventional treatment. Whereas on the other hand, we know that it's more or less difficult to assess the pulp status. It's challenging to find the right diagnosis. We know that there are also risks of inflammation, risk of necrosis, the famous pulp canal obliterations, resorption pain. And also we have to take into account the profitability of this treatment. What are the right protocol, considering that there are different protocols, and sometimes also on top of that, there are different recommendations from the different societies. And regarding the clinical outcomes, we have data. We have a lot of data in reality. However, we lack meaningful comparison. There is a large increase about the data, especially when comparing the biomaterials, but we don't have true comparison for the different situation. So we miss these randomized trials. Another thing is about the diagnosis. There is this famous study done by Domenico Ricucci, where we have the advantages when we read the article to have information about the clinical case, also the radiograph, and the teeth were extracted that allow him to do the histology. And for example, there is these cases where there are symptoms and signs of reversible pulpitis. But when we do, not we, but when they perform the histology, they found some micro abscess in the pulp, and in blue, the penetration of the bacteria. So it means that if you would have gone for vital pulp treatment, it would have failed on this case. And on the other side, on the tooth number 15, there was sign in this young patient, I think, of irreversible pulpitis, spontaneous pain. Teeth was extracted, and you can see on this histological section that the pulp is normal. There is no sign or very few signs of vasodilatation, no attraction of immune cells. And if you have a look on the mineralized bridge, it is a thick bridge with no bacterial penetration. This means that if you would have gone for root canal treatment, maybe it would be considered as over-treatment because there was potential for healing of the pulp. However, the conclusion of this article, in spite of these two clinical cases, is to say that there is a good agreement between the clinical signs and symptoms and the histological classification, especially for case of healthy pulp, reversible disease, I mean the early state of the pulpitis. It's more difficult for extremely severe pulpitis. And we know that there are current limitations also about our sensitivity tests. If we think about the trauma cases, we know that the nerve regeneration is much slower than the vascular regeneration. This explains why we have to wait before taking any decision in case of trauma cases. On the other hand, we also know that the nerve fibers are more resistant to necrosis and inflammation than the vascular tissue. That means that you could have a positive answer even in a case where there is a total necrosis of the dental pulp. So it can lead to false positive. So what could be the future of diagnosis in order to have an accurate status of the pulp, helping us to decide for the right decision? On one side, you have some physical devices such as laser Doppler oximetry. These devices are really interesting since they are able to assess the red blood cells movement inside the vascularization. So they are truly vitality tests. However, they are not used in daily practice since they are maybe complex and challenging to use. For example, I tested the laser Doppler, and it took me more than 1 hour to make a good assessment. And although there are very good comparative results when we look in the literature, they are not accurate when there is some cracks, when there are amalgam filling, and so on. That's why they are not new. They were assessed 15 years ago, and they are not in daily practice. I do believe that the future is more towards biological side with the use of biomarkers. We have a wide array of study that demonstrate some of the best biomarkers, such as MMP9, metalloproteinase 9, such as IL-8, such as TNF-alpha, or other inflammatory mediators that are correlated with the status of the pulp. However, we still need to have a sample. So the sample could be pulpal blood, or could be dentinal fluid, or also could be clavicular fluid. And also we have to obtain a chair-side result, which is not the case at the moment. However, if we consider all the progress that has been made in the last 5 or 6 years, we can think that in 10 years, maybe we will have some chair-side test in order to decide what would be the best treatment for the patients. One barrier that is often highlighted is the risk of the pulp canal obliterations. So what is the risk in terms of statistics? We have different studies, such as this randomized controlled trial that assess 12% of PCO, pulp canal obliteration, with partial pulpotomy in comparison with complete pulpotomy, where there was 25, and it's expected the more tissue you remove, the more risk you have to obtain pulp canal obliterations. So this obliteration there will lead to clinical signs of yellowish tooth with low to negative answer. And we also know that the more immature the teeth is, the more risk of PCO is. So this pulp canal obliteration or narrowing canals, they occur not only for vital pulp treatments. We know that they are naturally occurring. Sometimes also they could be associated with systemic health issue. They could result from the irritation of bacteria, but also from irritation of the pulp capping biomaterials, and also from the traumatic injury that was before our treatment. But the trick question is not to know what is the frequency of this, is to know what is the frequency of necrosis rates after vital pulp treatment that would have led to a pulp canal obliteration. So it's a bit more challenging thought. And to try to answer this question, there is this interesting systematic reviews that assess the adverse effect after vital pulp treatment. They assessed 11 articles reporting pathological narrowing, pulp chambers, or canal obliteration. And they found that most teeth exhibiting pulp canal obliteration maintain vitality and remain asymptomatic for years. And we can consider that these obliteration, they are signs of vital tissue. They are produced by the odontoblast-like cells. And we also know that the post-VIPT studies show that less than 5% of necrosis appear among the teeth exhibiting pulp canal obliteration. So there is less than 5% of this case with PCO that would need endodontic treatment, but it's true that in this specific case, the case will be difficult. So we would need some magnification in order to assess the color of the tertiary dentin that is usually more colored, darker than the other dentin. To try also to navigate between what has been done before. For example, in this case, the practitioner tried to find the canals, but ultimately lead to perforation in the crown of the teeth. So we can manage this case, obturate the perforation, fill the canal. Also, there are also other tools. We can use guided endodontic for these cases. What about the failures? Most of the failure appear in the first year after the vital pulp treatment, and half of the failure will be asymptomatic. So that's why we need to assess radiographically the cases. And I share with you one failure. It's a young man that came with a reversible pulpitis, and there was a major occlusal cavity on tooth number 37. So I did the vital pulp treatment. It was a proximal lesion, and I saw the patient for the different follow-up. And at 6 months, the pulp was diagnosed as necrosis, so it's a failure. So I performed the root canal treatment, but I asked the patient if he had any health issue or things to explain what could be the cause for this case. And he told me that he has been recently diagnosed with a diabetes, type 2 diabetes. And I don't know if it's the only cause or maybe the explanation for this failure, but we found that in the literature, when we compare the normal pulp of diabetic patient with non-diabetic patient, we have sign of fibrotic tissue, signs at the molecular and cellular level of a decrease in vascularization. So that's maybe also one of the explanation. Among the different barriers, we know from literature that there is an insufficient training globally, and undergraduate teaching is still emphasizing on root canal treatment over VPT, whereas the postgrad education correlates with higher confidence in full pulpotomy as a definitive treatment. And also, if we have a look on different survey made on dentists, many dentists still use calcium hydroxide instead of the hydraulic calcium silicate because of the cost, because also of the lack of training, the limited exposure of such cases, and some of them doubt about the reliability of the treatment, and also according to the different situation, different countries, the cost and the remuneration constraints. And I recently found this, that in the US, some of the public health insurance policies may not cover the root canal treatment cost if the patient has previously received a pulpotomy. And I would like to finish this lecture with a few words about my research work related to vital pulp treatments and what could be the perspective also of the future. The objectives, the aim, I think, for the future would be first to improve the management of the pulpitis, to overcome the limitations and the deficiencies of the current biomaterials, and to obtain a truly pulp regeneration. So for achieving all of these goals, there are different strategies based on physics, based on biomolecules, based on genetics. Our team, we work on stem cells and on some specialized mediators that I will detail a bit. So to obtain the regeneration, we cannot decorrelate from the inflammation control. The key of the regeneration process is to be able to modulate the inflammation, to obtain the resolution of the inflammation. That is the last phase of the inflammation, and this phase is actively driven by some mediators, and these mediators are called the specialized pro-resolving mediators. They have wide array of effects, such as cytokines decrease, such as stopping the neutrophil influx, such as switching the pro-inflammatory macrophages called M1 toward the anti-inflammatory called M2, also to help to the debris removal. We have data in periodontology, and for example, there are studies showing that there is endogenous mediators in periodontal tissue, and in case we restore the level of these mediators, either by endogenous or exogenous approach, we can promote inflammation resolution. And there is currently the first in-human clinical trial using the lipoxin A4, that is one of the SPM I'm working on. However, for endodontics, we don't have data about detection of this SPM in both healthy and inflamed pulpal tissue. We cannot correlate also the level of these mediators with the progression of the pulpitis. So what I did during my postdoc was to assess first whether these mediators were able to act on stem cells, in particular with stem cells of the apical papilla. And we shown in this result that there was the presence of the receptor first. The expression of the receptor here was increased when we stimulate the cells with LPS, that is a component of the gram-negative bacteria. And then when we apply or stimulate cells with LPS, there was an increase in IL-6, that is a pro-inflammatory cytokine, as expected. And when we use different dose of lipoxin, we had a decrease in the production of this mediator, and this was reversed by the use of the antagonist. And we did the same with 41 different cytokines. We also made some comparison with other immune cells, showing that there was an effect of these mediators. Then, based on this result, we also assessed the effect of this molecule on polarized macrophages, so key players in the immune answer. And we demonstrate that there was very truly positive effects. However, to be honest, these molecules are difficult to work with. One of the drawbacks is that they are hydrophobic compounds, so very difficult to use in pulp tissue, for instance. There is not a linear dose-response answer. They are not antimicrobials per se, whereas we know that in our field, we need also to have antimicrobial effects. And we know that we can encounter some patient viability and viability in disease mechanisms. So our idea is to create some emulsion within a gel that we call biphasic microgel. In the emulsion, you can encapsulate the molecule, the SPM, and then this emulsion will be put in a specific tunable platform about this hydrogel, able to achieve a controlled release of the molecule, avoid its dilution, to preserve the biological activity and stability, and also to serve as a matrix for tissue regeneration. So to make a long story short, I just share with you one of our last results last year in an in vivo model of pulpitis on rats, on rat molar. And if we have a look on this marker, CD163, that is a marker of M2 macrophages promoting the resolution of inflammation, you can see that there are more brown staining, showing that there are more CD163, so more M2 macrophages when we use the nanoemulsion loaded with the lipoxin. So to conclude with this topic, I would say that vital pulp treatments are totally part of the dentist armamentarium today, and I think that they are also technique and tools for the future. We lack next generation diagnostic tools that allow us to precisely know what is the status of the dental pulp. We also need some new biomaterials able to help for pulp regeneration, not only healing. And we lack comparative studies and data for our practice in order to obtain the best treatment for our patients. I really thank you for your attention. And of course, I will be happy to answer to you all of your questions. And if you are interested in this topic, I've created a QR code when you can download all these articles that helped me to design this lecture. Thank you very much. I will switch here.
Thank you.
Thank you so much.
Thank you very much.
I'm sorry,
Alexis.
Gianluca, I
Thank you
can't
very
hear
much.
you.
Can you hear me now?
Yes.
Just a second. Can you hear me, Alexis?
I can't hear you. I'm sorry.
Fabio, vedi se ti sente a te.
Can you hear me? Alexis? In teoria è tutto acceso qua.
Sì.
Alexis?
Vediamo. Non ci sente. Vediamo se gli scrivo un attimo su WhatsApp.
My speakers are on, but I'm sorry, I don't have any sound.
Okay.
Can you hear me, Alexis?
Do you listen us?
So I think I have the comments on the right side. So
yeah, you have the comments, Alexis. I'm writing. Let me check.
Okay. Try if there is something connected with Bluetooth, like iPhone, AirPods, or something like that.
Sto provando a dire se esce un attimo e si riconnette, Fabio.
Sì, oppure che guarda, che magari c'ha gli AirPods.
Adesso vediamo se esce. Adesso si dovrebbe riconnettere, quindi dovresti averlo. Vediamo, sì.
Perché a volte anche ha gli AirPods appoggiati lì.
Vediamo se riusciamo.
Perfect.
Okay.
Yeah.
Can you hear us now, Alexis?
Yeah. Yes.
Okay, perfect.
Okay, great. I want to thank you very much for this comprehensive lesson about the topic. It was really, really great. Thank you so much, because you enlightened us about all the possible different clinical solutions and scenarios. So thanks again, Alexis, very much. You can read the comments, I think. So there is, I have read a quite technical technical question, probably from someone from France, because he speaks about something related to the, I think to the insurance, if I'm not wrong.
No, so before answering this question, I have to give you a few words about the context, because in France we have something we call HAS, which is the health authority. It's not a society, it comes from the government, and it gives a recommendation that we have to follow. And last year there was a publication about management of patients with infective endocarditis risks. And in this document, we have a very accurate, detailed, and recommendation for vital pulp treatments. I think we are the country in the world with the most detailed recommendation for that. So for instance, and I think it was the purpose of the question, because I can't see it again, but it is said, or it is written in the document that you could do direct pulp capping for patients with high risk of infective endocarditis only for immature teeth. But you can't do the direct pulp capping for mature teeth, but you could do the full pulpotomy. So I hope that I won't lose anyone with what I've just said, but this document is really, really precise and accurate. It's an expert consensus, and the rationale behind this is that it's more risky to do the direct pulp capping on this patient rather than the full pulpotomy. But for immature teeth, we push a little bit, and that's why they recommend you can do it for these cases. So
very interesting technical aspect. Thank you for trying to explain us the context of this question. Thank you so much. Fabio, ci sono altre domande?
No?
Okay. I think there are not any more questions, Alexis. So I really do not have any more comment to do, because you was so clear and explaining every single detail that in so short time there is not that much space for any discussion. So I just want to thank you so much. There is another question that has arrived now.
He say if you think about chlorhexidine instead of hypochlorite.
Yes, so there is two questions in this question. So because we could use chlorhexidine instead of hypochlorite for two purposes. Could be for cleaning of the cavity, or could be used also for hemostasis. So for the cleaning of the cavity, there are some studies saying that chlorhexidine could have a positive effect for the non-degradation of the hybrid layer. So there are many, well, not many, but there are in vitro studies showing that, but we don't know from a clinical perspective or point of view, is it true or not? If we take into consideration the hemostasis side, we know that sodium hypochlorite is more effective than chlorhexidine. That's why you could find the sodium hypochlorite in recommendation from AAE or other societies. However, I think that there is still a place for the chlorhexidine in cases, for trauma cases, for instance. And I just would like to emphasize that we don't want to create the hemostasis. We just want to have a product that disinfects from inside, has some abilities to have the hemostasis. But if we really want to have hemostasis, we could use laser, for instance. But with the laser, you would have the hemostasis, but it won't help you to be in the best condition for the vital probe treatment.
Okay.
Thank you so much, Alexis. Crystal clear. Thanks a lot.
Thank you, because tomorrow I have a study club about lethal therapy. So
yeah, I saw the slide. It's a very nice slide.
It was a good starting point.
He has written down a lot of new things catch from your lecture. So Alexis, thanks so much again for your availability, and good luck for all the activities that the French Society is going to have. And I have been invited by your society in the past, and it has been really a great meeting when me and Nick came there in Saint-Malo. So I know the spirit of this society is very similar to the spirit and the ambient that we have in the academy. So we feel really happy for this cooperation, and that will continue also in the next year. So Alexis, we do not keep more time than this. Thank you so much again for this beautiful lesson, and stay in touch. Hopefully we will meet very soon.
Of course. Thank you very much for this very nice conclusion.
Thank you so much.
Thank you so much, Alexis. Have a good evening.
Yeah, have a good evening too. Bye.
Bye. Grazie.